Good morning, everyone. Good morning.
Good morning, Professor.
Yeah, good morning. Can you hear me, everyone?
Yep.
Okay, good. All right. So, 15 students. I think we have more. 7 more to join. Let me see. Yeah, 8. So we're okay. So 7. Okay, 16 now. Okay. Yeah. Before we start, so any questions before I start the lecture today? Does anyone have any question about the validation or the exam next? What is that? The 22nd. Third exam is 22nd next week, next Thursday.
I have a question.
Yes.
I was wondering where I could find the recorded lecture for the renal case study that we went over.
Yeah. Have you, read or did you see my email announcement last night?
Yes.
Have you checked your email? Yeah. I said that I have 3 Zoom lectures already uploaded. The cardiac and I think 1 renal, I believe, right? There's another renal and 2, 1 burn and the trauma. these Zooms, the last three, I couldn't upload or post because of the I exceeded or exhausted all the space on Blackboard. So I have kind of like used all my quota for the for posting in terms of the space, like or you can put any more of these videos up uploaded or on the Blackboard. So I have to wait until I gave like a I believe until Friday midnight, right, for everyone to save whatever we have on Zoom recordings on Blackboard. Then I will be post like removing them so I can post or upload the new ones. That's what I, when I sent that email last night, yesterday, last night, that's what I meant. To be able to upload the new ones, I can do that until I remove or delete the old ones.
Okay, thank you.
Okay. Any other questions? Okay, so we know that the exam, right, next week, 22nd, the second exam, and that will include, you have the study guide anyways, but just want to go over the Neuro to be, clear on what's will be included from the Neuro content, in which that I will start today and then I will continue that on Tuesday. So to be able to complete the content or to to spend more time on Neuro, is that okay with everyone? From the plan is is to spend longer than like 2 hours on Tuesday. So how we're going to do that is that we will start at 8, and then I'm probably going to end by maybe 11. So I'll check with the section 2. That's going to affect section 2 more than section 1. Section 1, your section, if that's okay with you, because I can 3 hours I can cover more, or a little bit less than that, maybe like 2 hours and a half, maybe. That I can cover, most of the Neuro, or like, without rushing. So I spend more time, like, time to go over all the content and give, examples and case studies and answer the questions. And so that's that's my plan, to have both sections next week on Tuesday from 8 to about like 10:30. So that way we can cover more content and answer your questions. Now, if that's okay with section 1, I will move on to X. As section 2, when I ask them, then I'll confirm it with an email or with announcement saying that it's going to be the plan for next week. Is that okay with everyone in this section? And it's going to be also recorded too as well. So it will be a recorded lecture too. So if you have a class from 10, or at 10 for your section, if you have a class at 10, then you probably are going to leave and miss like 30 minutes of the class. But anyways, it's going to be recorded, so you can view it and you can watch it as a video.
I think that's fine.
Any one has a problem with that? Okay, then I will move on to section 2. If that's okay with them, then I will move on and plan for that, because we need to spend more time on Neuro. It's a huge and lot of very comprehensive kind of content. The Neuro content that will not be included in exam 2, and that's and that will be in exam 3, will be the TBI, traumatic brain injury, increased intracranial pressure, brain tumors, and I will also plan not to cover it next week on Tuesday, so we'll have, time to cover the other content that is going to be included in exam 2. Also, the other content that will not be included in exam 2 will be last week guest speakers lecture, not the trauma. The trauma will be included because that includes some questions about the spinal cord injuries, for example. So the content that will not be included in exam 2, the guest speaker that Mr. Ralph, who came in for the Burns lecture from St. Barnabas, and the stroke also, which is stroke is going to be. I have a case study for that, but also it will be posted as a PowerPoint slides from the students, like student presentation, a group of student presentation will be posted as on Blackboard. So again, one more time, the content that will not be included in exam 2 and it will be in exam 3 will be burns, stroke, CVA, TBI, ICP or increased intracranial pressure, and brain tumors. Everything else from the neuro will be in the exam 2, like Parkinson's disease, seizures, spinal cord injuries, MS, ALS, GBS, which is Guillain-Barré syndrome, MG, myasthenia gravis, TN, which is trigeminal neuralgia, Bell's palsy, which is the facial palsy. So all these neuro content areas will be or disorders will be in the exam 2. TBI, ICP, brain tumors will be in exam 3. In addition to the burns and stroke also will be in exam 3. So that just to clarify and make sure that we're all on the same page with what I have in the syllabus and the exam or content in exam 2 and exam 3. Any question about that? All right, so let's start with the breast cancer. I usually do not go over breast cancer and because it's a pure online module and I used to assign like a day, for an online module, not because prior to the pandemic when you have like face-to-face 100% in face-to-face classes, and so I assign always one day or one lecture for the breast cancer, so that will be done like independently. You have lots all content needed content for the breast cancer, and then case studies and questions, and but I will just go over the most important concepts from the breast cancer. Make sure that you understand the difference between the both major types, the diagnoses, treatments, medications, most commonly used meds, and post-op. You will find that in the PowerPoint slides. I'm not going over the post-op, but post-op complications. The most important complication would be the upper extremities edema, the edema that would result because of the removal of the surgical removal of the lymph nodes. So let's start with some case studies, and I will spend about like 30 minutes on this topic, and then we'll move on or switch gears to the neuro content. Okay. So the first case study, does anyone have any stories or experience or work in oncology unit or have any input before we start about the breast cancer? Okay. Okay, so section 1, I will start from the reverse alphabetical order. So we need volunteers to read, the case study and and so we can answer also the questions. Carla, is Carla here?
I'm here.
Yeah. Okay, Carla, can you please read the case study?
So the setting is an office. The chief complaints are my mammogram showed a lump. The vital signs are normal. History of present illness is a 44-year-old woman who just had a mammogram that showed an abnormality, comes to the office to find what the next step is. The patient's mother and sister both had breast cancer, so when she went to a random health fair in her neighborhood, she was advised to get a mammogram earlier than age 50. She feels well.
Okay, good. So before we get into the question, what is the message from the HPI? What we can learn from the HPI? And this is a question for anyone, I mean, like, for everyone, not just you, Carla.
There's a history of breast cancer.
Okay, there is a history, but like lesson we can learn as healthcare professionals that we can also teach, the lay people, not just, patients, also lay people, public.
Starting to get mammograms
Mammograms, okay.
earlier than the age of 40.
Mm-hmm.
Yeah, the age, I think you should start getting mammograms if you have a family history.
Mm-hmm.
Like I think it would be A at 35
Okay.
because you have that family history because the mother and the sister has it.
Mm-hmm. Good. So which means that, the message is that the prevention, screening. So screening for breast cancer is very important, given that also the BSA, breast self-examination, BSE, I'm sorry, the testing and also the mammogram, according to the protocols, certain age. We'll go over that in a minute. So prevention, prevention, prevention. That's the point here, which is screening and prevention. So the which is a public health kind of topic. You will go probably you will cover a part of this in community health nursing next in the spring. So at what age? So which leads us to the age groups or recommendations or recommended age age for the mammogram, when it should be done, and that depends also on some other factors. So Carla, what do you think? The answer at what age is mammogram?
So because she has a history, I mean, we would want her to get, a mammogram earlier, like age 40, but for the general public, they say 50 or younger.
Okay, for the screening, you will find different numbers, and even among textbooks, but the national recommendation from the national health, I mean, like departments and from the CDC, and that the cancer also, American Cancer Association, for women at average age, at average risk, the screening mammogram is recommended to begin by the age of 50. This patient has a history of the patient have a significant family history. So the first relative, first degree relatives, we include siblings and parents. So in her case, she has a high percentage of risk. So she should be to start, should start at least at age of 40, not 35. 35 is still still that early. You sometimes hear this number from, certain practitioners, but we will go with 40 and 50. 40 for individuals who have a history with like family history, and without will be 50. So the woman in the general population has a risk of 1 in 9 without a family history. But with two, given this, like this patient has two siblings, or two first degree relatives with breast cancer, so the risk goes up to about 40 to 45%. So we'll go with 40 with risk, and then 50 without. Next is TN. TN, are you there? Shanika?
With her family history of breast cancer, besides starting screening early, which would be best to have prevented breast cancer? Would it be BRCA testing since it runs in her family?
All right. BRCA testing. Can this prevent breast cancer? The BRCA 1 or 2? When you do the BRCA testing,
Well, can it technically? Because after they get tested, if they're shown to have a strong indication for it, then they could do something like remove their breast, which can help prevent it. So can it be used as preventative?
No, the BRCA test doesn't prevent cancer. So just to get that, notion is that the BRCA testing, it doesn't prevent cancer. It is associated with 10%, with 10% of patients with familial breast cancer. And this patient, we already know she is at high risk of cancer. So also it's not clear with, when it comes to the BRCA testing, it is not clear what the BRCA offers for us. It's still very controversial, area, like a gray area. And I know that, some celebrities, they do the, prophylactic mastectomy based on the BRCA testing, but it's not that clear area. So it's not clear the benefit of the BRCA testing, it's not clear yet. The treatment that will definitely prevent cancer to a high extent would be a very well-known and widely used medication. And it can reduce it down to about 50% in the risk in patients with, people with high risk of breast cancer. Which is?
B, tamoxifen.
Tamoxifen. It's a widely used medication, or raloxifene or tamoxifen. It prevents breast cancer from even occurring in the first place. It has proven a very effective outcomes because it is a SERM, which refers to the, or abbreviation for selective estrogen receptor modulator. So it's an SERM. This is a group of medication of selectively modulate the estrogen receptors. They're very effective to, and will give us about 50% reduction in the risk of breast cancer. And there is, again, heavily and widely used in those females with first-degree relatives who are at much higher risk of breast cancer than the general population. And it's proven to be very effective medications. Now, the breast ultrasound, it's used when the lump is detected in a younger premenopausal patient. That's can be the case. But it doesn't differentiate between lesion, if solid or cystic, or that's the limitations of breast ultrasound. The MRI, the breast MRI, it's useful in evaluating firm breasts with unusual architecture. So it has like a limited use, and we'll talk a little bit after that, after in the second case study about the ultrasound and MRI. And we said that the BRCA, it's testing the benefit of that is not clear, and it is associated with only 10% of the patients with families of with breast cancer. But this is, in this patient, we said that this patient has a high risk having 2 first-degree relatives with breast cancer. So the BRCA, again, it tells risks without a clear therapeutic path. It doesn't give us much in terms of what next or what should be done. Or I know that, again, some people will electively agree or go for the prophylactic mastectomy, but this is not always the case. Okay, next is Sarah Williams here? Maria?
Yes, hi.
Yeah, hi. Yeah, can you please just read that?
Which of the following wait, you want me to read the patient returns?
Yeah, let's just go over, the results of the testing, or the because patient has an initial order of needle aspiration biopsy. And before I get to that, just to highlight the SERMs, or the selective estrogen receptor modulator medications like tamoxifen, is that they will be antagonizing the cells or receptors at the breast tissue or cells, but they will be agonists at the bone, endometrium, and clotting factors. So it'll be antagonist at the breast cells, but they will be agonist at the bone, endometrium, clotting factors, which means that that could be the side effects that you can deduce from being agonistic at the bone, endometrium, and clotting factors. And I will also again go over also the side effects in a few minutes. So the report, Maria, report. Mm-hmm.
So the patient returns after the breast biopsy, which shows infiltrating ductal endocarcinoma of the breast. The report shows estrogen receptor was positive, progesterone receptor was positive, no cancer mammography of the breast, and HER2 and EU antigen increased. Which of the following should be done next? Don't they look at the sentinel node before they do any of these? Isn't that always the first one? So
Yes.
our go would be
B, perfect. Yes. So before I move to the testing and which one is be more effective, and there's like a timeline for each one. Now the selective estrogen receptor modulators also, again, we said it decreases the breast cancer risk, but at the same time we said it's an agonist to the bone, endometrium, and clinic factors. So for the bone, it will be problem with osteoporosis, and with the endometrium will cause the endometrial cancer. Now, as we look at the risk-benefit ratio, we will find that these selective estrogen receptor modulators like tamoxifen decreases the breast cancer risk much more than increase endometrial cancer risk. So the predictability, or like possibility, or the risk from of endometrial cancer will be way less than the or it will be less than the reduction in breast cancer for those who are at risk. And we have certain, like, I can't go over numbers, but it's a little confusing. It's just to know that there is a risk of putting the patient on tamoxifen, and one of the risk factors would be the endometrial cancer. But the drugs, they decrease significantly the breast cancer risk, way much more than the increase in the endometrial cancer risk. So just to highlight that, because I just mentioned about the side effects of that might be, may result or might result from the use of this tamoxifen. So back to the testing and what would be the most more like appropriate testing done at this point. The sentinel node node biopsy, which is sentinel node. And when we say sentinel node, what is the sentinel node from the pathophysiologic or from the pathologic perspective? The sentinel nodes are the first few lymph nodes into which the tumor drains. In other words, that it's the first cells that the tumor, so these will be the first cells in which that the tumor, when it develops to become cancerous, these are they are in transition to become cancerous. So these are like preliminary cancer cells. So the sentinel node biopsy sentinel is a surgical procedure used to determine whether the cancer has spread beyond a primary tumor. So sentinel node can give us an indication, give us some, an idea if there is some any movement or any traveling or any invasion of these cells to adjacent cells. So especially into the lymphatic system. So it will determine, this surgical procedure, it determines whether the cancer has spread beyond the primary tumor into the lymphatic system. And it's they use what is called the contrast media, and they will remove the first, the node that the contrast media, the contrast media will be, when they inject it, it will right away goes to the sentinel nodes, and they will know that these sentinel nodes, because of the the change of the color of the cells, and they can excise them and remove them. And it has to be sent to the histology or histologic examination. Okay, and Stephanie Vasquez.
Okay, so as you have the results for the neo biopsy and the mammogram showing a unilateral unifocal lesion, you should proceed to order the procedures as needed. Order surgical consultation, oncology consultation, sentinel nodule biopsy, lumpectomy, radiation of breast tissue. Suppress estrogen synthesis through inhibiting aromatase.
Yeah, so this is just the to highlight the importance of these drugs and the treatment of patients with breast cancer. So that which is in the other set of PowerPoint slides, number 40. That's so the lumpectomy. It's a modified radical mastectomy only if breast is radiated. So radiation, and they will do lumpectomy. Without radiation to the breast, to the breast cancer, recurs with lumpectomy alone. So it's just radiation supposed to be done right away after the lumpectomy is done. So after lumpectomy, then radiation should be applied or done to make sure that all the cells that might be cancerous has been irradiated and um, uh, died. There's another set of medications. So before we get into that, we have testing called HER and TR, which is estrogen receptor, PR, which is progesterone receptor, and we have the antigen. So at least just from these testing to know that we have HER2 and we have even HER1, but just to know that when these tests are positive, there is a high risk. So when there is these high positive high, there will be high risk for breast cancer. So mortality rate. One more thing about the estrogen receptors and progesterone receptors is that when we do when the breast tumors are tested to see if they are positive or negative for the estrogen or for progesterone receptor, the hormone receptor tests, these hormone receptor tests, they are both are used for prognosis, like to evaluate the prognostic and predictive for future like therapeutic management. So tumors that are estrogen receptor positive and progesterone progesterone receptor positive, so both are positive, the ER and the PR, they are slightly slower growing and they have slightly better prognoses than the tumors that aren't. So this is just an example of how we can use the ER and the PR when they are positive. So if both positive or either one is positive, means that the tumor is growth is slow, and it has a better, slightly better prognosis than tumors that are negative. So it's not always a negative thing to have, to have ER and PR, either one or both positive. There are a lot of medications to treat patients with breast cancer, and the approved, we have the two groups of approved medications to treat. The first one is called AI, which is the aromatase inhibitors, AIs, aromatase inhibitors, like the Arimidex, for example, the Femara, the aromazine. And then we have also the other group of medications. When that's when the metastasis, or patients or women with metastatic breast cancer, we use a hormone therapy options like the Faslodex and the Megace. And I think some of you have heard this medication being used also, the Megace, which is megestrol acetate. Megestrol acetate or Megace. It's like a milky kind of consistency and color, and looks like it's a milk of magnesia. This Megace or megestrol acetate, also it's the off-label use. If you have seen this, used for in like older adults or patients with, especially older adults, yeah, when they have a poor appetite. So it stimulates. So the off-label use for this neoplastic agent for breast cancer is also, it can stimulate appetites. That's why you see, so, older adults, or patients with with poor appetite will be on Megace for that. So, so which of the following will lower mortality the most? In other words, medications that will be used to prevent metastasis.
Adjuvant therapy, chemotherapy?
Yes, the adjuvant chemotherapy are the most effective medications to lower mortality the most, not the first, second, or the oophorectomy. Oophorectomy, which means
Your eggs.
right, the removal or excision or surgical excision removal of the ovaries. So the adjuvant chemotherapy provide a definite mortality benefit. The adjuvant means chemotherapy that is used to prevent metastasis. And it's not prophylactic because patient already has cancer. Again, aromatase inhibitors are the medications, also AIs used to treat patients with cancer. They called examples of that: Arimidex, Femara, and aromazine. So which of the following is the most, let's see, who's here? Sarah Texera? Is Sarah here? Ashley Strom. Ashley? Is Ashley here? Ashley, can you hear me?
Oh, sorry. My headphones are down. Sorry.
Yeah.
Which of the following will lower mortality the most? Or you want to this one, right?
Yeah, we did this one. Yeah. Yeah,
Okay.
next one.
Which of the following is the most common adverse effect of aromatase? How do you pronounce that?
Aromatase inhibitors, yeah.
Okay. Which of the following? Since we're just talking about, I would say ovarian.
The aromatase inhibitors, we remember when I said it has significant effect on the it's an agonist on the bones, so it will cause osteoporosis. So because the aromatase inhibit the estrogen production with side effects including bone loss. So the
Oh,
yeah.
that makes sense.
Mm-hmm. Yeah.
So would you
So
take that
us,
as in addition to something else?
you mean
Like you would take the inhibitors, but then you would probably take something else to
yeah, definitely they have
counteract
to
it?
be on. Yes, they have the AIs aromatase inhibitors. The patients also should be on like Fosamax, on medications to prevent osteoporosis. Yes, prevent the measures like Fosamax. Mm-hmm. Yeah. All right. Thank you. And Catherine.
To provide blockage of estrogen in the premenopausal woman, Liberalide and Goserelin are sometimes given to prevent the need for a factorectomy. How do they work? Maybe this.
Yeah, it's just a mechanism. Yeah, it's a mechanism of action. Um,
They decrease the release of luteinizing hormone and
the LH and FSH luteinizing hormone and the follicle stimulating hormone, yes, will be decreased. So they decrease the release of these two hormones from the pituitary gland. So the treatment that will lower back to the the concept of because this patient undergoes radiation therapy to the breast after the lump is removed surgically. So surgical removal of the lump was done, and then patient underwent irradiation therapy because the lesion is over 1 centimeter. It's bigger, larger than 1 centimeter. Then the chemo is given. So in general, we can just list the treatments that would may lower the mortality would be like surgery, modified radical mastectomy or lumpectomy with radiation. The patients who had the HER2-NEU, which the test, one of the tests the patient had, and it was positive, then they will be treated with a specific medication that are going to target this receptor. And this medication is called Herceptin. Another widely used medication called Herceptin, Herceptin. If like extra HER2 present in terms of the testing, patient showed large amount of HER2 NEU receptor presence, then they will be treated with the Herceptin. Trastuzumab, that's the generic name for the brand name called Herceptin. You will find the other name it's the generic name for that for the Herceptin is called Trastuzumab. But the Herceptin is more, you will hear even practitioners, all the time they will say Herceptin, not the other name, because that's very difficult even to pronounce. So that's so we have surgery, which is the modified radical mastectomy with radiation. Second, patients, these would lower the mortality. Patients with large amounts of or high numbers of HER2 testing, they will be treated with Herceptin. That's going also to lower the mortality rate to a large extent. And then 3 will be the adjuvant chemotherapy. And the last one is the SERMs or aromatase inhibitors, the AIs, the selective estrogen receptor modulators like the tamoxifen or the aromatase inhibitors like Arimidex. Okay, next is Minji.
A 27-year-old woman has used oral contraceptives without problem for 5 years. However, she just read an article about complications of the OCs in a popular women's magazine and asked you about the risk and hazards of taking OCs. Correctly tell her which of the following. D. The risk of bearing a child with major congenital anomalies is increased.
No. So what's wrong with D? D is not correct answer. Anyone knows what why D is cannot be correct? Like it's an incorrect answer, like wrong answer, or in other words, it's a distractor. How D is a distractor?
Because if you're taking oral contraceptives, how would you be pregnant?
Right. Yeah,
I don't know,
that's one. Yeah, that's one thing. Right. Exactly. But also, yeah, which is what comes to your mind. I mean, you know, the first thought would be that notion, right? So how do you know a woman be pregnant when she's on or contraceptives? But also in well-controlled studies, in terms of like, you know, the research studies, there is no increase in the risk of having a child with a major malformation or cardiac malformation or limb abnormality. There is no risk. So these two reasons. So D is incorrect.
So would it be C?
Yes.
I think what tripped us up was the decreased.
Exactly, because the incidence of ovarian cancer in oral contraceptive users, it's about 50% less than that found in non-users. Even though it is, it will be decreased too. The ovarian cancer will be decreased, but it's not to a high extent, like 90%. I'm sorry, yeah, 50% ovarian cancer reduction. The incidence of the PID, the pelvic inflammatory disease, is also decreased in about 50% in OC users. But the risk of the endometrial cancer is decreased by 50% after 1 year of the oral contraceptive use, and the protective effect. So this is the point here too. Not just the reduction will be about like 50% reduction, but also the protective effect seems to persist and stays and be sustained even after they stop taking the oral contraceptives. So in fact, it will stay, you know, stay for even some, like, you know, not sure that will be like months or years, but the effect will be also the protective effect of the drugs will seem to persist after stopping the oral contraceptives. The risk of ectopic pregnancy is reduced by 90%. Reduced by 90% because the risk of the so that will be so again, you know, that could be the one good hint actually that the everything is increased except for that decrease is C. So C is the correct answer. All right. Marie?
A 35-year-old G3, P3 woman has been experiencing bilateral breast pain for the past.
So Marie, what is G3, P3?
The amount of pregnancy she's had.
Right. So that gravida 3, para 3, right? Yeah. All 3 pregnancies brought life, you know, children.
Yeah. Breast examination and mammography are normal. Conservative measures have failed. Which of the following medications is most likely to bring relief? Um, would it be the tamoxifen?
Mm-hmm.
No.
Yes. Yeah.
Okay.
Clomiphene, which is Clomid. What would be one of the side effects of clomiphene or Clomid? Aside that it may have estrogenic side effect, which in other words that will increase the estrogen and it worsens the the breast pain. So it's going to worsen the condition, not improving the breast pain. So what the clomiphene also has a significant side effect.
What would you use that for?
So what is the indication of clomiphene?
So you said it increased estrogen, but
Exactly. So what do you think? If it increases estrogen,
menopause,
no,
right?
osteoporosis,
estrogen. What do you need? These
Treating
hormones of
infertility?
estrogen. I'm sorry?
Infertility?
Infertility, yes.
Mm,
Yes. So infertility, for those women who take the clomiphene or Clomid, they large percentage of those who used it and had pregnancies and became pregnant after that. The problem is, and which is one of the most serious side effect, is that they have multiple births. So they have twins, twins. Most of the pregnancies that become pregnant, most of the time they will have twins. So the progesterone, which is the last medication, which is medroxyprogesterone, many women who receive the progesterone, they note that they develop the breast discomfort and pain that's secondary to the fluid retention and fluid overload from the effect of that hormone. The hydroxychloroquine, the hydrochlorothiazide, which is the HCTZ, it doesn't have any effect, or it is irrelevant to the question. Karen? Is Karen here? All right. Jackie? Is Jackie here?
no.
Karen's not here. Jack is not here either. No. Annabelle?
A 55-year-old woman has a bloody discharge from her last breast. A mammogram discloses a cluster of microcalcification 3 cm beneath her left nipple. Which of the following is the best next step in her evaluation?
Okay, boys and girls, if you're done writing your name, you can put your pencil down. We're going to be looking today, and we're going to repeat it. know, look for the word.
Annabelle said D
Remember,
as in
each
dog,
is
right?
spelled
Yes.
Okay.
A.
Yeah, thank you. Yeah.
So you're gonna follow along with your
You have
finger.
a loud back noise.
I'm
Can
sorry.
you mute? Can you? Yeah, I know that you have your kid. Okay. Yes. So the age-guided precautions. I'm sorry, percutaneous biopsy. It is preferred because the fine needle biopsy has about 20% false negative results or rate. So the fine needle, again, the fine needle biopsy, it has about 20% false negative results. So it's, you know, the image-guided percutaneous biopsy is preferred over or more effective in terms of diagnostic. So the also both the bloody discharge from the nipple and also the microcalcifications, both are indicators for the breast biopsy. The cystology or the cytology, it's a screening tool. So it is mandatory, it's recommended that if in the presence of a significant risk factor for cancer, that a tissue diagnosis, it is mandatory. So it's recommended that we do a tissue diagnosis in the presence of the significant risk factors. So cytology, it's not recommended. It's, you know, cytology is a screening tool. Okay, Maria Kostiska.
Which of the following principal advantage of a fine needle aspiration of breast? Wait, I'm sorry. Which of the following is the principal advantage of a fine needle aspiration of a breast mass? Would it be E? It helps to determine the extent of the breast carcinoma. Wait. No. I would say B. I would change it to B.
It reduces, right, the number of open breast biopsies, yes. So the advantage, or more than one advantage of fine needle aspiration of breast mass, that it can distinguish between a cystic and a solid lesion. And it reduces the number also, the number of open breast biopsies, because breast biopsies is going to be like an open, open surgery, when it's positive for cancer. So it reduces, so it's benefit, the advantages of that, at least two. It can distinguish between a cystic versus the solid lesions. So it's good for differential diagnoses, and also it reduces the number of open breast biopsies when it is positive for cancer. The negative needle biopsy is a non-diagnostic, and so most surgeons, like breast surgeons, most of them, they will not perform a definite surgery like mastectomy or lumpectomy with lymph node dissection without histologic confirmation of cancer, like using the core needle biopsy, surgical biopsy, or frozen section at the time of lumpectomy. Some surgeons, they prefer what is called the frozen section. Anyone knows what the frozen section is? Frozen section, though, yes. Anyone knows? So the frozen section in the OR, during the surgical, like the surgeon will start the surgery to excise the lump or lumpectomy or or mastectomy, or modified mastectomy, and then they will instantly they will excise a tissue and send it to the lab for what is called frozen section, and then wait in the OR. The surgeon will wait for the results. Takes about 15-20 minutes, to get the results from the lab, and they will move on, continue, and they will do the subsequent step based on the results of the frozen section. So all of these are tests, different tests, done for breast cancer. Emily?
Which of the following factors is associated with the greatest lifetime risk for developing breast cancer? Is it E?
I know that all of these are possible factors or risk factors, but can you recall from pathophysiology, we said number one risk factor is not just for breast cancer, for all different types of cancers. So the highest risk factor for all different types of risk of cancers, any cancer, like all different types of cancers, when it comes to risk factor, number one, the highest will be
E.
What was it? Or is it A? Obesity.
Remember when in pathology we said the cancer develops, or the patients, when they have cancer, the cancer and the pathophysiology of cancer, it takes 3 steps and phases: initiation, promotion, right? So the steps, and there is some mutations, and that mutation is basically that our immune system our immune system is attacked daily, on a daily basis, with mutations, and our body corrects it. Our genetic makeup will correct these mutations. So we call that genetic hits, and the longer that we live, the more genetic hits we can accumulate. So if let's say that you survey the cancer and the general population, you'll find that it is the highest prevalence of all different types of cancers will be among who? Older adults. So in other words, that the age will be the highest risk factor, not just for breast cancer, for all different types of cancers. So all of these are risk factors, yes, but the most important one is age. So the factor associated with the greatest lifetime risk for developing breast cancer is age of the woman, because the genetics risk factor or the heredity breast cancers account for about 5 to 10% of all breast cancers, and give the woman a relative risk of approximately like 2. We have risks goes from like 0 to 1, 2, 3, and 4, and so we go like numbers like that. So if so with the relative risk is about 4 when the woman has a first degree relative. It goes from 2 to 4. But the age always it's going to be the most important, and that will increase the risk of of breast cancer and all different types of cancer as well, and the population. Joseph?
Which of the following is the most common type of breast cancer? I would say it is C.
Yeah, we have in the other set of PowerPoint slides, you'll find the different the different types of breast cancer, two most common ones, and the most common type would be D, which is infiltrating ductal carcinoma. Infiltrating, which is in other words, it's invasive ductal carcinoma, which accounts for about 65 up to 80% of all breast carcinomas. The infiltrating lobular, which is B or C, which is lobular carcinoma, it accounts for about 10 to 14%. All the other types of carcinoma will account to about 50 or less percent. So the most common one in terms of the prevalence is the infiltrating ductal carcinoma. And you will find the differences between them and the percentages also in the PowerPoint slides. Thank you, Brianna.
Which of the following is the best predictor of survival after appropriate treatment of breast cancer?
So what would predict the survival rate or time, predictability in terms of if you're going to predict?
The axillary nodes, E.
Negative for cancer. Yeah, there's a controversy about that. Yeah, although the survival decreases as the number of positive axillary lymph nodes increases, the role of the sentinel lymph node biopsy and axillary lymph adenectomy has become controversial. So there's a controversy about that. And there appears to be like a trend against the axillary lymph adenectomy, especially with ductal carcinoma in situ less than 1.5 centimeters in terms of diameter of the tumor of the. So in women with the primary tumor of 1.5 or 1 or 1.5 centimeter or smaller, and so it's the size of the tumor that's the most important predictor for survival or of survival. So in women of the tumor size of 1 up to 1.5 or less centimeters or less, the recurrence risk is approximately 15%, primarily because the likelihood of complete excision is greatest, because the smaller the smaller the diameter of the tumor, the high likely that the tumor is going to be eradicated completely, excised surgically completely. So the likelihood of complete excision is greatest. So we basically can remove every single cell. When it's small, it's very simple, very easy to remove the tumor completely. When it gets bigger than 1.5, then it's very difficult to remove all adjacent cells. You'll be careful as you excise. Demetria?
I'm not sure.
Um,
Is it A?
No.
Would you do a breast ultrasound? Can you find?
Ultrasound.
No. Oh, maybe. Okay, so at 30 weeks gestation, it might be her.
It's two to 3 centimeters. It's not small.
Okay.
It's 2 to 3 centimeters. It's not small tumor. Yeah. So even it's it's rare to in women younger than 35, the breast cancer is rare, and greater than 35. The approximate incidence of breast cancer in pregnancy is 1 in 3,000 deliveries. So survival rates the survival rates from breast cancer and pregnancy are less than in non-pregnant women of comparable age. And that's always due to delayed prognoses. So what would be the best diagnostic? In other words, diagnostic tool. Ultrasound is not going because it's 2 to 3 centimeters. It's not going to be effective because breast ultrasound, provides about a large percentage of false negative results. The accuracy for diagnostic purposes, ultrasound is not going to be effective at this point. So we will recommend the fine needle aspiration.
Even though it's 2 to 3 centimeters?
Yeah, yeah. Fine needle
Okay.
aspiration is the best, tool or diagnostic tool for breast cancers or tumors of that size. Okay, and yeah, so we have a lot of content in under the breast cancer and endometriosis, and so you will go over that, PowerPoint slides, and meanwhile, between now and next week on Tuesday, if you have any questions about that, we can, I will answer it. So we have to switch gears. We spent like an hour. What is that? Yeah, 1 hour 20 minutes actually on that. So let's just at least we have to start the neuro. Okay, so the first case study would be about the Parkinson's disease. All right. Brianna, did you answer any question?
I answered the.
Oh, okay. Then Amanda now. Thank you.
You just want me to read it?
Yes, please.
A 74-year-old man with progressive inability to walk over the past year comes to APN's office. He also has a hard time getting up from a seated position, and he becomes lightheaded when he tries. Past medical history is osteoarthritis, medications, acetaminophen, general immobile, seems very grim-faced. Neurological tremor at rest at 3 cycles per second, cogwheeling present, slow gait, significant retropulsion. He cannot easily turn, orders for an MRI of the head and a Chem 20.
Okay. So our first question. So what is the, okay, well, let's just go over the question and then I'll explain the Parkinson's disease. Go ahead.
Which should be tested for on examination? C?
Okay, yeah. Automatically we'll say spasticity of muscles, but it's not the spasticity, it's rigidity. Rigidity and rigid muscles is different than the spastic muscle. And the that video, it's one of the best videos, perfect one to watch, and because it differentiates between the rigidity and spasticity. When the muscle is spastic and it's rigid, and in patients with Parkinson's disease, they don't have a problem with spasticity, it's with rigidity. So C will not be the correct answer because of that. So that's my recommendation, is that everyone to watch this video, please. All right, so if it's not C, then
is it B, orthostatic hypotension?
Any explanation?
I think it has to do like behind the whole patho of it with the dopamine. Well, because you have a decrease in that usually like plays a part in like the voluntary muscle and the sympathetic nervous system. So since you have a decrease in that, then that
right, exactly, yes. Because remember that with the Parkinson's disease, patients develop that this disease because of the imbalance between the acetylcholine and the dopamine. Right here. So there is an equilibrium imbalance between the amount of dopamine produced by the brain cells and acetylcholine at the junction, or the neuromuscular junction. So the acetylcholine, it will excite, excitatory enzyme, and then the dopamine, it's the inhibitory. So it inhibits the, let's say that this is a control. So this is an individual with no Parkinson's disease, and this is a patient with Parkinson's disease. This individual, or healthy individual with no Parkinson's disease, is that they have a controlled movement. So controlled movement because they have a balance between the excitation and the inhibition, the acetylcholine and dopamine. But when the brain is at some point, or especially with older adults, is that the brain cells will decline in terms of producing the dopamine. So that will result in that we have more excitation and less inhibition, and that's what result in instead of controlled movement, that there will be disturbed movement. Now, the effects or the signs and symptoms that also, aside from the rigidity of the muscles and the repetitive movement and disturbed repetition of the movement, there is also an effect, that will also affect the ENS, which is autonomic nervous system. So the autonomic nervous system is slow to respond to these changes. So there will be, we expect there will be an issue or problem with orthostatic hypotension. So what would be the hallmark manifestations of patients with Parkinson's disease?
They would have tremors, the mask-like face, bradykinesia.
Right. So bradykinesia, which is the slow movement or slow active, everything is slow, right? And then rigidity of the muscles, rigid muscles. Good. And there's a phenomena in Parkinson's, they call it cogwheeling. Cogwheel phenomena is also known as a cogwheel rigidity or cogwheeling. It's a type of rigidity of the muscles seen in people with Parkinson's disease, which is usually an early symptom of Parkinson's disease, and it can also be used for diagnosis. So there's no test to specify actually the diagnosing patients with Parkinson's disease. The MRI of the head can be used to see if there are previous strokes that led to the patients experiencing the Parkinson's disease, because the PD also can be a result of the previous strokes or CVAs as a risk factor. So the MRI can be used to identify any previous CVAs as a risk factor for Parkinson's disease. So the orthostatic hypotension, again, because the patients, when they cannot easily get up from a seated position, when they're like in a sitting position and then stand up, then they will have orthostatic hypotension. So as they rise, the ANS, the autonomic nervous system, is slow to respond to the changes in the blood vessels. So the normal increase in pulse rate and vasoconstriction, that is the normal response, which is as we change position from sitting to standing, we don't experience the orthostatic hypotension because the ANS response would be, that's the normal response, would be to the increase in pulse rate and heart rate, pulse, and a vasoconstriction. So we don't feel that lightheadedness, that's kind of, we don't faint, we don't feel that signs of hypotension. But this response is not occurring, is not going to be present in those patients with ENS problem, with Parkinson's disease. So that could result, again, with the orthostatic hypotension, could result in an experience of syncope and syncopal attack. Okay, Felicia?
Okay, which of the following should, I'm sorry, which of the following should you also or examine for? Would it be B?
Right.
B?
Right. Memory difficulty, yes. Acetylcholine helps with memory formation to form the memory. Short and long-term memory is based partially on acetylcholine amount or presence, or so we need acetylcholine that will help our memory formation. The inhibition of the ACH acetylcholine will provoke dementia. So this is why the anticholinergic medications like benztropine is hard to use in those older adults, like 60, 70 years old. It worsens the Alzheimer's disease. So it's anticholinergic medications like benztropine, it's not recommended in older adults because it worsens, makes it worse, the Alzheimer's disease. We use drugs like, what other drugs can be used for Alzheimer's? We had a patient last week with Alzheimer's disease on the medication for Alzheimer's. Donazepam, which is Aricept. So these are, drugs for Alzheimer's disease like Aricept, donazepam. We have Exelon, Rezidine, that's used for Alzheimer's disease, and they increase the acetylcholine and improve memory. So there is a connection between acetylcholine and the memory deficit or a memory. In addition that, as we inhibit the acetylcholine or inhibiting the acetylcholine, it should cause tachycardia, constipation, and dilated pupils. And this is, from the pathophysiology of the effect of the anticholinergic drugs. So anticholinergic drugs means increasing the pulse. It will result in constipation, dilated pupils. Just on a slide, this is just to review some of the pharmacology with you. But the answer to this one is that the acetylcholine is heavily connected with the memory difficulty. So less acetylcholine will, in other words, inhibition of acetylcholine will provoke dementia, and we will and also anticholinergic drugs would cause, what are side effects from anticholinergics would result from the anticholinergics, other than the dilated pupils. Dilated pupils will result in what is called glaucoma. So glaucoma as a side effect from the anticholinergics because of the dilated pupils. Okay, next. So, the question of acetylcholine and dopamine, there are, some areas that we still have no answers. For example, why does decreasing the acetylcholine will increase dopamine? I know that the dopamine and acetylcholine, they are both present at the junction of the neuromuscular junction, but we don't know why when we increase acetylcholine, when we decrease like anticholinergic, when we decrease acetylcholine, that is going to increase the dopamine. And that's what we need. We need more dopamine at the receptor in patients with Parkinson's disease. Jiwoo, Bay?
The new order to DC benztropine and start amantadine when you assess the patient again in 2 weeks. There is no significant improvement. What's the next step to try?
Medications to treat, the meds to treat patients with Parkinson's disease So the patient, yeah, benztropine was said. Benztropine is not good for patients with Parkinson's disease because we mentioned, we explained why about the acetylcholine. So we will start amantadine, Symetrel. And no improvement. So what would you said Comtan. What would you use Comtan?
Because it's a new version. I don't know. Sorry. I'm not sure.
We are looking for medications that have a direct acting dopamine receptor agonist. Medications that have a direct acting dopamine receptor agonist. And these medications, we know that the patients will be on levodopa, carbidopa, like cinema, and they have less efficacy than the levodopa, carbidopa, like cinema, but they have less side effects as well. So we need the meds that are effective with less side effects. We always, number one, anytime, we take care of patients with Parkinson's disease, automatically we'll find them on cinema, right? So we'll be on levodopa, carbidopa. But the B, which is Requip and Mirapex, these medications, they are dopamine receptor agonist, and that's the standard of care in most Parkinson's disease patients, is to try the dopamine receptor agonist. So we recommend always that our patients to be on these medications first because of the efficacy of the drug and the limited number of side effects to these drugs. So the Neuro1, which is the generic, brand name is Requip, R-E-Q-U-I-P, Requip. And then the other one is the Pramipixole, which is a Mirapex, M-I-R-A-P-E-X. And Requip also, another uses for Requip for prenorol, Rapinirole, Requip, any other uses for Requip other than for Parkinson's disease? And it's very, very effective. For anyone knows what is Requip is used for? Like other than the Parkinson's disease.
Restless leg syndrome.
Yes, exactly. Restless leg syndrome, RLS.
Isn't C also a dopamine agonist?
The Paralidil? Paralidil, yes, it is. It is a dopamine agonist, but is a derivative of ergot, and it has more side effects such as nausea and vomiting. So if like choosing treatment, if two medications have the same efficacy, then we are definitely going to use the one with less side effects or adverse effects, right?
Yeah.
Yes. The Selagiline, or Selagiline is the last one here, which is the, what is that? Selagiline?
No.
Which is the it's a MAO inhibitor. It's a MAO inhibitor, and this one, it decreases this drug of class of drugs, the monoamine oxidase inhibitors. They decrease the metabolism of dopamine, but the efficacy is unclear. So it's kind of we can use it as trial, but it's not cannot guarantee the the outcomes. And again, also the amantadine, which is the symmetrical efficacy, is also very limited. And amantadine, also symmetrical, may increase dopamine release from substantia nigra. That's the mechanism of action, how it, it works. The mechanism of action of symmetrical amantadine is that it increases the dopamine release from the substantia nigra. So the COMT or the COMT inhibitors like COMTAN is it's just A. It's a class of a drug from class, it's a drug from the class that inhibits the enzymes called COMT, COMT. And it's not effective like the other meds that we just mentioned. They block the mechanism of action of these medications, that they block the metabolism of the dopamine in the brain. So it doesn't affect the production, but it will block the metabolism of the dopamine in the brain. So we'll have more dopamine not being metabolized. So they enhance the activity of the dopamine at the substantia nigra. We can use it, but we cannot use it alone by itself. Like, they have a definite efficacy, but they are not exclusively an add-on therapy. In other words, that we cannot just use them alone. We have to use them with other medications, like Sinemet, levodopa, carbidopa. By themselves, they will not work alone. Like, they will not work by themselves. Just COMT or inhibitors, it can be used, but we have to add on, or had to add another medication like levodopa, carbidopa to be effective, or to result in effectiveness, or to result in good outcomes in treating patients with Parkinson's disease. Okay, then Rosali. Is Rosali here? Rosali? Okay, so anyone? So we'll end with this question. Anyone has an answer for this question? So we said that the rabinurol, which is the requip, so the practitioner ordered the requip, and next visit the practitioner will see the patient again 2 weeks, seeing modest improvement in mobility and orthostasis, and then a year later, then patient is stable, begins to deteriorate again. We added the Sinemet, levodopa, carbidopa, and then we see a marked or significant improvement. What is the mechanism of carbidopa? A, which is direct dopamine agonist.
Agonist, so it's a dopamine promoter. Or am I completely
Okay, well, yeah. All right. We'll take a look at this picture. Have you seen this before?
Yes.
Okay.
A long time ago.
All right. So levodopa, yeah, the dopamine, it's in levodopa, not the carbidopa. So levodopa is the drug, the actual dopamine supplement, the actual dopamine, right? The carbidopa, the carbidopa, it's added to the levodopa. So carbidopa will be added for, first of all, the levodopa, which is the main ingredient. Just, you know, think about this as a main ingredient of the drug, and then we add, you know, we add the carbidopa to the levodopa. The levodopa, which is an ingredient, normally has a very short half-life. So it will decompose and not allow for the transfer across the blood-brain barrier into the brain. See, how's the blood-brain barrier? So if you, this is a comparison between a patient who will take just levodopa of 125 milligrams, and in yellow we have the actual amount of dopamine being disintegrated, destroyed, because we need the effect to be in the brain right here. So patient who is, you know, who would take 125 milligrams of levodopa, and this is another I mean, this is a patient who would be on 25 milligrams of levodopa with carbidopa. So this is without, and this is with. So this explains the effect of the carbidopa. First of all, because the levodopa, it's, and this is a large dose of levodopa. This is a small, very small, tiny dose. 125 without carbidopa, what would reach the brain will get only 2.5 milligrams, because most of that levodopa is gone before crossing the triple B, which is blood-brain barrier. And then another patient will be on levodopa with carbidopa with levodopa. Then patient will, the end result of that would be exactly the same, 2.5 milligrams would reach the brain. So which is the outcome? This is the outcome, the whole drug taken at 25 milligrams with carbidopa to another patient who would take only levodopa without carbidopa. So this explains that carbidopa will prevent this kind of peripheral disintegration, peripheral damage, because this is a loss. All of this is going to be a loss, and it can be prevented if it's taken with levodopa, with carbidopa. The levodopa also has a very short half-life, and so the carbidopa is a peripheral dopamine carboxylase inhibitor, so it will prevent, the carbidopa will prevent. Felicia, can you please mute?
Sorry.
Okay. Yeah, so the carbidopa is a peripheral dopamine decarboxylase inhibitor. In other words, that the carbidopa will allow for a large amount of drug to enter the brain. So this explains how patients on the effect of the carbidopa on the levodopa, that it will inhibit dopamine decarboxylase. Any question about that?
No, that makes more sense.
Okay. All right, good. Okay, so yeah, I have to, you know, we'll stop and then we'll continue on Tuesday. Again, we'll meet on Tuesday at 8, but I have to confirm that with, you know, the second, you know, section 2 about if we're going to spend like 2.5 hours on Tuesday so we can cover more content. All right?
Thank you.
Okay.
Thank you.
Take
Dr.
care.
Mickey?
Yes.
Dr. Mickey, the exam starts at 8
Right.
on Thursday?
Yeah. All exams will be 8. Yeah. According to the syllabus, go to the Blackboard on the syllabus and the weekly outline. You will find that all exams will be 8. All exams.
Okay, thank you.
Yes. Take care.
Bye, Dr. Mickey.
Bye-bye.